Thanks. It's a pleasure to be here today. So I'm going to talk a little bit about how we have brought some of the ideas from Partners in Health, that was mentioned in one of the videos, that is doing, how do you do preferential healthcare options for the poor? How do you create delivery systems in areas where there is no healthcare? But then how do you take some of those lessons learned and apply them here, where some would argue we have a glut of healthcare, but aren't necessarily delivering it in the best way? So we talked a little bit about reverse innovation, and I think my only point is to say that we have to keep in mind that it's not just about reducing costs, but improving quality. And that's a wonderful way for us to kind of stay true to the mission to make sure that everyone is benefiting from technology and that we don't have implementation bottlenecks, so that there are some people who can't access technology and others who do. And this is becoming more and more an issue in the United States. We spend more than any other country on healthcare, and we don't have the results to show for it. And there's more and more push, I wouldn't say a burning platform yet, but for us to come up with ways to provide more effective and satisfactory care at lower cost. And I think for those of us who are really focused on health disparities, that gap is growing. So just to kind of talk briefly about reverse innovations that I think are either happening or potential, I love this idea. There's this, again, company in India that has created a senior citizen phone, and it costs them about 67 cents a month. And there's this huge red SOS button, and if the elder gets into trouble, they push it, and it sets off this really annoying loud siren. But then it sends this SMS messaging to all these people that the people have chosen to be activated to respond. But also, interestingly, right away, the crucial medical information, the person's personal health record, comes up so that anyone reaching out to the person, and people can use GPS to find the elder, is made available. What a great thing to come here to the developing nation as our population is aging. Health houses in rural Iran. So I was just in the Delta region of the Mississippi, where there's obscene levels of poverty and poor access, in addition to a dearth of primary care providers. And there's Dr. Aaron Shirley, who for a long time was the only pediatrician in Mississippi, was saying, you know, we're spending all this money, but we're still seeing a huge disparities gap. And what can we learn from other countries in terms of how they've structured their health care and bring it here to the United States, because our system isn't working to meet the needs of these people. And so he partnered with Iran, who had come up with this really great idea of how to deliver rural health, using community health workers and setting up these health houses, much like we heard about before, where there's stepwise care from the community health workers into regional medical centers and then to tertiary hospitals. And he's actually starting to build these health houses in rural Mississippi. His biggest challenge to date has not been conceptual or buy-in, but really on finding funding to continue to scale up. And somebody asked a question about, you know, how can we learn from other delivery systems, perhaps aside from procedural innovation. And this is an example of an NGO in India that actually realized that not only is mental health under-addressed, but there are not enough mental health professionals to address it, even if screening uptake were to increase. And so they've trained community health workers how to deliver basic counseling and psychological support to the community, and have really shown in randomized control trials that people's motivation and ability to function in their lives has significantly increased. And this, again, is a model that we can bring to bear where there are deficits in terms of mental health care. So talk a little bit about the project that I've been fortunate to be a part of for almost 20 years. So the Pact Project is, as mentioned, we really tried to learn from our partners overseas and how could we bring some of the learnings there. But as mentioned, we have also done a lot of innovation that they are now applying across the seas. And so the partnership that develops as we learn from each other is really tremendous. But just to kind of set the stage for this work, what we realize in the United States, even with the advent of tremendous technology, highly active antiretroviral therapy, and a significant decrease in mortality rates, this happens to be a graph of AIDS mortality rates, that there's a disparities gap. That you can see that if you happen to be a Black woman living with HIV in the United States, your death rate is significantly higher. And in Roxbury, which is one of the inner city communities that really buttresses my hospital, if you happen to be a Black woman living there, you're 15 times more likely to die from AIDS than a white man in Boston. And this is really what led us to think about what is it about the way that we're delivering care that isn't working. And at least in Massachusetts, which is a relatively progressive, wealthy state, this wasn't an issue of lack of insurance or lack of access to medication. And what we realized was the disparities really had a lot to do with poverty, and I don't just mean fiscal poverty, but poverty in terms of social capital and marginalization and the ability to set as a personal goal your health, to feel like you have a future, enough to invest in the hard work that it takes to navigate the healthcare system and prioritize your health over other things that get in the way. And one of the issues that we learned very early on from doing a lot of community-based research was that the fundamental lack in many of these communities was a lack of support and a lack of hope and a lack of, yes, education and knowledge about how to navigate the system or advocate for oneself. But many of those things could be overcome with the addition of what we call an accompaniteur, someone who accompanies. And so we started the Pact Project in 1998 as the US Project of Partners in Health. And we really felt that we needed to use people from the community as the agents of change. And why community health workers? There's lived solidarity, they have lived experience, similar cultural linguistic backgrounds. They take a contextual, holistic approach to health in a way that we are untrained as biomedical professionals. And really for us too, the building of social cohesion and really the opportunity to create meaningful work in these under-tapped communities was also tremendous. Now, community health workers are not, it's not a novel concept. It was first used in the global setting, actually in China. And it's interesting now that they're moving away from that. It'll be interesting to see when they move back in terms of using the barefoot doctors. But they've been around the US for a long time, since probably the 1960s. But they're not as optimally used in the US as they are abroad. And there are a lot of reasons for that, but a lot of it has to do with the fact that medicine has become very professionalized and biomedicalized. And we fail to recognize that so much of someone's health is dependent on their social factors rather than their access to technology. And community health workers have been traditionally used more as coaches or navigators or linkers. And what we're trying to say in the United States is, going along the lines of the notion of task shifting, what other roles can community health workers take so that we are really narrowing that disparities gap? And I would argue that although it's sometimes useful to think of them as task shifters or physician extenders, it's really important to recognize that they are offering a unique value to healthcare, that they are doing things that no other provider can, and that they can work at the top of their license or the top of their capacity and really provide a critical role in the delivery of high-quality, low-cost healthcare. So what do health promoters do? I mentioned the concept of accompaniment. And I'll share with you a quote that our community health workers say: "What I do aside from doing health coaching and education and making sure they get to their appointments and teaching them and watching them swallow their pills day in and day out, is I walk shoulder to shoulder with someone, and I'm not pushing them from behind or pulling them from front, but living with them as they experience life with their chronic condition. And that accompaniment in and of itself is so incredibly therapeutic. And a CHW will tell you, I teach the person how to learn to love themselves again. Their work is community-based and home-based, which is really critical in our view, making sure that that is not marginalized as a site of care, that we really need to bring back the idea that healthcare should occur in the patient's context and environment, that pulling them into our artificial environment of the clinic or the hospital detracts from our ability to really create a therapeutic alliance and to create an effect that is meaningful. We've developed a curriculum to train community health workers to deliver really standardized evidence-based health interventions. So we've looked at all of the different care management approaches across the United States, across the world, and we've tried to say, how can we teach the CHWs to deliver this, again, in complement, as part of a care team, to individuals who are struggling to take advantage of the resources that we have. And one important thing too, and I can say this as a provider who works with community health workers, is that they really model culturally competent care. There's something about having a community health worker in the room where you're being witnessed, which makes you a much better provider and much more likely to really listen and come up with a treatment plan that is real, that is relevant, that is likely to be effective when that person goes home. This is just an example of some of the driver diagrams that we've developed. So for instance, the hospital to home transition, which is a particularly difficult time for patients where a lot of people really lose momentum and are readmitted, causing costs. And we think about all the different things that one can do to facilitate a better transition. And one could argue that so many of these things could be done by a community health worker. And so this is an example. We teach patients about the red flag. So you're admitted with an asthma flare or you're admitted with congestive heart failure. What are the things you need to watch for between now and a couple of weeks when you see your provider? And so we've created then a curriculum to basically help train patients using low health literacy materials and a lot of feedback from both community health workers and patients alike. In terms of our work and our results, we've had about 15 years experience accompanying a very special group of HIV patients in Boston. And when you look at them, they're primarily people of color, they're poor, they're undereducated in a formal sense, but I would say overly educated in dealing with historical and current trauma. A lot of people with depression and substance use, and many of them have had HIV for 12 to 13 years. And when they're referred to us, are typically referred to us because they're dying, or the nurse, the 7 case managers, the AIDS service organizations have all been struggling for years to find solutions and just can't get to really connect with them in a way that makes a meaningful impact. And what we've done in Pact is we've really created a 3-tiered model of intervention. And this is an example of a reverse innovation where we're helping some of our partners now in international countries really take on this kind of dynamic, flexible model where you apply a different intensity of community health worker intervention based on the person's need over time, and you use metrics to decide when and how often they need a ratcheting up or a ratcheting back of intervention. And so we have some patients, so about 30% of our patients at any time need daily support. So we have a community health worker who goes into the home every day to help them take their meds. Whereas there are some who eventually only need monitoring once a month, and people go in and out of these arms over time. And I think one of the things that we see when we're thinking about chronic disease is there's this kind of fallacious thought that someone can be taught how to self-manage or how to adhere. And a lot of times you see interventions that are like a 12-week course using M&Ms on how to take your meds, and that they're okay. But what we find is this is really not an educational gap. It's a life crisis issue. And so when people are having issues that crop up over time, they need more support. And then our job is to know when to pull back so that you can create the cost efficiency and really think about the economy of scale. So these are some of our results. It's not rocket science. You help people adhere to their meds and get to the doctor. You see their viral loads go down. You see their CD4 counts come up. And we've seen over and over again that in taking this approach, that you can actually see reduction in expenditure. So we did an all medical expenditure analysis using Medicaid data and saw that within 2 years, there was about a 60% decrease in hospitalization, all hospitalization, not just AIDS-related hospitalization. Obviously, an increase in use of outpatient and pharmacy services, but this was offset by the reduction in inpatient costs. And when we did an analysis, saw that there was about 16% net savings to Medicaid. I don't have time to get into later why we are not scaled up, despite showing these data to a population that is primarily paid for by our public payer system. And we tried to do a lot of training and technical assistance across the country in this accompaniment model, and really thinking about how can we apply it to conditions other than HIV/AIDS. But I think most excitingly is we're thinking about primary care transformation. How can we really integrate the community into solutions? And how can we create teams, again, where everyone is working at the top of the license, but we're also taking advantage of these tremendous community assets in terms of finding solutions that make sense. And I wanted to just spend a little time talking about the community health workers. There's thousands of names for them. You probably have them here too. But at least in the United States, they were only recently recognized as actual worker type. It was in 2009 by the US Department of Labor. And a lot of states are really struggling with what to do with this workforce. There are only 2 states in the United States that actually have recognized or regulated enough that they can get reimbursement through payers. And a lot of states are struggling with how do we introduce this lay person into healthcare? What do we do about risk and liability? How do we reimburse for them? You know, how do they work within a system that, for those of us who work as providers in the US system, is so broken? But they remain a very vulnerable workforce, and many times they're basically taken on with soft money and grant money, but then when that's lost, they're gone. So these are a huge list of challenges, and I had to stop myself because I was getting depressed as I'm thinking about scaling up CHW interventionists. I think the biggest issue in the United States, and you're not dealing with this here, and so there are times when I wish I could come to Canada and practice. The biggest issue for us is just a malaligned financial system. So right now, although that's beginning to change, if I go to a large hospital system that hasn't kind of signed on to the accountable care philosophy, and I say, you can hire people from your community, that's great PR for you, you can be on the front page of your local newspaper, and I can cut your hospitalization rates by 50%, drop your hospital costs, drop your ER frequent flyer costs. They look at me like I'm crazy because that's lost revenue for them. And so until we fix that problem, any sort of movement towards these kind of community-based solutions is going to be really challenging. And I think that there are also acculturation issues. When we go into systems that have, quote unquote, drunk the Kool-Aid, the idea of having a lay, non-licensed, non-professional member in the team, in the office, is somewhat threatening. And it's very challenging also, and I would argue, that in healthcare, we haven't figured out how to manage people, how to do quality improvement, how to use data. This is starting to change, but until we can have that base infrastructure, it's very difficult to implement, let alone innovate and implement. And obviously, one of the things that is near and dear to my heart is how do you deal with some of those upstream determinants of these poor outcomes in terms of the poverty and the racism, because we have to deal with those societally too. And what an incredible opportunity for those of us in healthcare to be true advocates for the poor and disenfranchised, because they're the ones who suffer the most. And just to end, I wanted to give you a case study. I had the good fortune of going down to Arkansas last week, and it's one of the poorest census tracts in the US, and there's a huge lack of employment. It's still a plantation economy, but a lot of the black labor force has been really marginalized, and many of them live on disability checks. And a huge number of people, about 50%, who are uninsured, and a larger number that are then underinsured. And the statistics, as someone mentioned in the back, really rival some of those of developing nations. And Arkansas is one of the only states in the rural South that has actually signed on to the Medicaid exchange and trying to increase access to healthcare insurance for its population. And this was an opportunity for us to partner with a Tri-County Rural Health Network, which is this phenomenal grassroots organization that started along the Delta in Helena, which used to be a thriving steamboat community. And they are community connectors, so these tremendous black women who basically have been going into people's homes and helping keep the disabled and elderly from being institutionalized. And we were called by them to say, how could we really potentiate these community connectors to start to work within this healthcare reform and really improve outcomes? So have them work as interventionists in settings where primary care is rare or poor quality. And I think the answer to that is yes. And it's a wonderful thing for those of us to start to think about how we could piece this together and bring lessons learned to an impoverished area. And I think I agree that we have to set these little fires to create our own burning platform, because it's hard to sometimes see that there's going to be a large-scale systemic change that will really close that disparities gap. And so my dream is in 5 years, and I know that's overly optimistic, is that our US healthcare system has been overhauled, and we really think about the structural forces that are impeding good health. And we think about health and not just health care. And that we think about patient outcomes and quality driving payment, and that we've really figured out how to pair the traditional clinic-based system with community-based clinicians and think about how we can provide high-quality care to everyone in need. And I'll stop here and answer any questions.